patients who come in with acute MI showed no reduction in mortality, but it did show further reduction in LDL. The number needed to treat in this population was 55 over a median of 6 years. And ezetimibe is a pretty cheap drug, considering. PCSK9 inhibitors. So these trials, I'm going to show you. I'm going to skip through this.
What's the metric you use to calculate that? It's not deaths because there's no difference. So is that?
It's reduction in cardiovascular events.
Events.
Events, not death. Right. With this PCSK9 inhibitor, the number needed to treat was 63 over a median of 26 months. With alirocumab in people after acute MI, these, mind you, these are people who are already on statins and have further risk reduction with secondary prevention. Their LDL remains above 70 despite statins, and in those people, they were effective in reducing future MIs, hospitalizations, and revascularizations, and the number needed to treat was 64 over a median of 2.8 years, so pretty similar. We have been collecting patients at UCSF. Crystal was able to compile 54 of our patients that are treated in our clinic and compare them to Fourier and Odyssey trials. And we see that in our population, we do a lot more primary prevention. So the number who've had a prior MI is only 26%. So I think we're pretty aggressive at lowering. We get a lot of referrals of people with FH. I think that's the main difference in our clinic. And this is also our data, our percent change in LDL cholesterol from baseline. This was again compiled by Crystal. She does most of our approvals and follows these patients. And you see that there's a wide range of effects. Even some people had increases in LDL. And I think these are the FHs that have LDL receptor mutations and just don't have any effect. And that's why we see the change, depending on what diet and weight and all of that. So in people with diabetes, this is interesting. It's a data from the data comparing evolocumab and Fourier, simulation of ezetimibe and Fourier, simulation of evolocumab and IMPROVE-IT, and it calculates the cost to prevent one major adverse cardiovascular event. And look at the prices. The ezetimibe in IMPROVE-IT, $10,000 versus $620,000 and $678,000. So, just food for thought there. This is a very future directions EPA. So, fish oils have not shown to be very effective at preventing events. However, this study was done with a highly purified EPA called icosapentaryl ethyl for hypertriglyceridemia, and it was significantly decreased cardiovascular death. The number needed to treat in this trial was only 21. So it is something that we are probably going to put in our tool belts, and I am already using it in a couple of patients, and it's been highly effective. This is another new drug. It's called bempedoic acid, and it's a cholesterol biosynthesis inhibitor. It's a statin alternative. It blocks the adenosine triphosphate citrate lyase, and it's 2 steps upstream from the HMG-CoA reductase, which is the target for statins, right? So it's further upstream. It blocks the cholesterol synthesis, similar to statin, but the bempedoic acid is converted to its active moiety in an enzyme that's not present in skeletal muscle. So it's not going to give you the myopathy that the statins could produce in some patients. So this is going to be a good alternative for those people. The studies using BPA and plus or minus ezetimibe are currently in phase 3, and we're hoping to apply for the NDA in 2019. So hopefully we'll be able to use those drugs also. So when I was talking about that studies with ezetimibe and PCSK9 inhibitors have confirmed that lowering the LDL will reduce cardiovascular event regardless of the agent's use and proportional to the degree of LDL cholesterol lowering. Okay? But even with aggressive LDL reduction, the vascular events continue to occur at an alarming rate, suggesting that there's additional factors at play. So here's where the role of inflammation comes in. And what I want to show you here is how many targets, possible targets we have in the inflammatory cascade, right? From inhibiting the VCAM, ICAM adhesion of the macrophage to the vascular wall, the oxidized LDL, the LPPLA2, the CRP, the IL-1 beta, and all of statins here inhibiting the cholesterol synthesis, colchicine, which prevents the inflammasome from assembling. So we are going into an era where people are excited about trying these new drugs to fight inflammation. So this is a slide showing the residual risk of major cardiovascular events following cholesterol reduction. So see, with statins, high-dose statins, ezetimibe, and PCSK9 inhibitors, the risk reduction still has ways to go. So we have a lot of work to do. So right now, we are treating to 2 targets at least. So we want to reduce LDL and we want to reduce inflammation. And this is why. So when you only reduce, when you don't reduce either one, so when your target's LDL is above 70 and CRP is above 2, that's the recurrent vascular event rate in the blue. When you reduce the LDL, it comes down. If just your CRP is reduced, it's similar. But when you are able to get both down, you get additive effects. Okay, so now when people come into the clinic, I follow their LDL and I follow their CRP. I wasn't a big fan of CRP. I prefer the LPPLA2, but I saw that following it was not as clinically important. At least the studies hadn't shown the effectiveness of doing that. So that's what we're doing right now in our clinics. And this is just showing the relationship of the plasma levels of this IL-6. So CRP is produced by the liver. Let me see if I have the, right here. Is produced by the liver, and it's downstream from all of these processes. So it's a nice summary of all of these inflammatory molecules, okay? And we are able now to target IL-1 beta or target IL-6 with low-dose methotrexate. Let me see if I have it. So this is the first study that showed that therapy blocking with an antibody, the IL-1, decreased CRP and decreased events. The interesting thing is that it decreased it only with a 100 milligram dose, and it also reduced cancer mortality. So that was a huge finding. So inflammation is involved in both. Let's see. Yep. Oh, thank you. I'm sorry. So with this finding, the CANTUS trial provided proof of concept for the inflammation hypothesis. And then they tried with methotrexate, which was a much cheaper drug, and it didn't work. So methotrexate is not, unfortunately, wasn't effective. You see here the curve. So let's see. Now there's ongoing trials using colchicine, which is another drug that is accessible and already FDA approved, that we could use these. The role of inflammation was recognized in the cholesterol guidelines, and elevated CRP, rheumatoid arthritis, lupus, psoriasis, and HIV are associated with elevations in inflammation. The only thing is that in patients with inflammation, you are more likely to prescribe a statin because you know they're at increased risk. So the guideline recognizes this. Here's a cartoon showing the HDL, how it's synthesized by the liver and delivers cholesterol back from the artery wall. It's not a great cartoon. But. So what are our future directions? Is it possible to customize diets that target inflammation and lipid lowering? Yep. And so we're moving towards these plant-based diets, not only for health, but for the environment as well. How does the microbiome contribute to the inflammasome? These are great areas of research, and probiotics and these great world of opportunities to change our flora and change our inflammatory status, our HDL remodeling. And I think that anti-inflammatory pharmacotherapy is going to be another tool in our belt. Let's see. So this will be, I think, my last slide, how the 2018 AHA scientific statement on atherosclerosis, cardiovascular disease in South Asians in the United States. This is a very urgent problem. I think this was a great step towards increasing awareness. I think we all had this idea that South Asians were at risk. There were no guidelines. It identifies some key risk factors that drive the risk, and they ensure that the message is disseminated. Okay? So let me show you. I tried to, it appears to come down to biology, why South Asians have more aggressive disease. They get it earlier in life. When they get a heart attack, they die more. They're more prone to dying. They get it earlier. And it seems to be enhanced common risk factors. They have higher rates of diabetes, higher rates of high blood pressure, higher body mass indexes, higher levels of cholesterol, and combined hyperlipidemia. What has also been found is that the cutoffs that we use for general population are too high for the South Asians. Their waist circumferences should be smaller. All of these things, they're in the guidelines. I encourage you to look at them, and they're very informative. The diabetes is also needs to be treated earlier. Diet. Let's see. Do I have a good news? Oh, the when you get an intervention in a South Asian, it goes well. They're similar, but they require, if they require more than one stent, the South Asians, the bad news is that they have poorer outcomes as well with CABG. They tend to stenose their bypass grafts earlier. That is just a manifestation of more aggressive disease in them. So what do we need to do? We have to include education, healthy diets, exercise, talking with doctors about the risk factors. So, oh, and I'm just going to talk a little bit about the terrible burden of climate change. I think that it's all good that we are trying to prevent heart disease, but if our planet is going to be destroyed, I think we and I think we need to not only think about cardiovascular diseases in the context of, you know, as individuals, we have a mission with our planet too, because whatever is happening out there is going to impact us. And physicians, we are taking, you know, initiatives. They are resources as a response to climate change. And I just wanted to leave it on a better note. Optimism is the faith that leads to achievement, and nothing can be done without keeping hope and confidence. That's Helen Keller, and I'll give.
Yeah, here, I can.
Knowledge is
Thank
power.
you.
Thank you.
That
That
was
was
fascinating.
So what I heard was that, you know, these guidelines are great and they're comprehensive. They ask us to look at all the different modalities, but we still have to personalize care for our patients and consider the innovations and deal with the data that's coming at us. We'll take one burning question if there is one, otherwise we'll keep on moving. Does anyone have a burning question for Dr. Staub? And we'll have more time in the breakout group. So let's just keep moving. It's my pleasure to introduce Dr. Tatyana Kanzaveli.
Not a doctor.
Oh, no, sorry, not a doctor.
One of the few in the room.
Not a doctor. But she has, you've already heard, is a chess champion, but also has really gone from, you know, a programmer to a CEO of a startup working in AI, blockchain, digital health, and today she's going to be talking a little bit about one of her products, My Cardiac Coach, that's partnered with the American Heart Association, which helps bring the resources to the consumer, to the patient, because as much as, you know, physicians and healthcare providers are involved in all these different facets, ultimately the patient is the one who's going to take ownership in the coming era to take responsibility for their care. And that's what we want too. We want patients engaged in their care. And so how do we help facilitate that? Because it's hard enough for us to manage all this information. So you're going to help us figure that out, right?
Yeah. Well, thank you for inviting me to present. I'm thrilled to be here. And as I mentioned, I'm not an MD, but I've been caregiver for my grandparents and parents. My father had everything you can think of from heart disease point of view, high cholesterol, diabetes, heart attack, and he passed away from heart failure. So I researched every single EKG, every single test he has been doing for a number of years. But and I've done it all, meaning in my life I was, you know, besides being a chess player, I had master's in computer science. My PhD was that I initiated before leaving Soviet Union was in AI, and then I worked with Pricewaterhouse for a long time and been an entrepreneur, doing everything from CEO of fashion startups to everything else until something happened. I was diagnosed with cancer. That kind of was a wake-up call for me to focus on things that matter. And at that time, when I stopped planning my funeral and try to get out of depression and everything else, as you know, a data person, I started asking questions, and was it related to causation and potential treatment outcome of chronic diseases such as cancer, and all the different data points that can impact that. So I built some kind of chart and looked at lifestyle, environmental, genetics, and everything else. Because no one could tell me why it was me doing cancer. That's when I started my company, even before my cancer surgery. And I was lucky enough to join by exceptional guy, professor in AI, PhD from Cardiology, Dr. Svetovat, who is my co-founder. So we started this company, and we decided to do things somewhat differently. The goal was to gather all kinds of data that impact conservation treatment outcome of diseases, and includes everything from genetics to everything else. How to get there? We need to engage with patients because we understand that lifestyle, diet, and everything else does have significant impact on outcomes. So, and that was, our vision. And what we've decided to do, some of the things you have mentioned in terms of what works, what doesn't work, instead of building yet another app or a chatbot, and we went through that phase where those things tend not to work, most of them are not used, we decided to build an infrastructure that enables healthcare organizations to create what they want without spending tons of time and money, but do it in a very smart way. And what I would do here, our platform is agnostic in terms of diseases, and it's even agnostic in terms of who the users are. So UCSF developed an app that's used by physicians and medical students, and they're productizing it. So we build all the building blocks that's configurable, customizable, to enable you to create what you need to make impact on people's lives. Right? So the example I'll show you is an app that has been developed by American Heart Association on our platform. Everything that you can see can look differently, can have different pieces to it, configurable, customizable. It's white labeled, so it's your solution. So when you look, this is one of the examples. We've done stuff in chronic pain, addictions, cancer, and autism, you name it. So this is an example. Now, you know better than I am all those things that increase likelihood of cardiovascular events, right? And can we use digital health tools to help people to manage their lifestyle, diet, everything else to decrease those risk factors? If you look, based on my experiences, and I've been doing that for quite a while, there are a lot of similarities across diseases in terms of people adopting usage of tools. You realize that everything has to be patient-centered, and I have slides on that. I mean, we can't tell people to buy just one device and use it all the time, because that doesn't happen. They still like certain devices. Even in my family, some people use one device versus another one. I did run data on usage of the app by American Heart Association that I'll be showing you today. We have clear cut, 50% Android users, 50% iOS. So it's not one. So it has to run on any device. Multilingual, it's important for people, especially elderly people, or to be able to communicate in the language they really understand well. Integrated. When people are ill, the last thing you want to tell them, oh, here's an app where you manage medication, here's where you do diet, here's where your appointment, and here's your test result. I mean, I'm healthy, I'm not doing that. But if you're really sick, you want to come to one place and be able to do most of the things that you need to do to manage your disease and life. Adaptive, you had the slide, one size doesn't fit all. You can have beautiful content on overall heart disease. If it doesn't take into consideration me, my age, everything else I have, and everything else, I'm not using it. It's not adaptive to me and engaging. So let's look at a few things that matter when we talk about patient centricity. Because anything we do in digital health has to have those pieces addressed in some shape or form. Care team. So I was caregiver for my parents. I managed their medications. I called my father 3 times a day to get his readings on his blood pressure. if you have complex diseases, you have nurses, you have caregivers, family members. So you can't expect them to go to multiple places. So you have to have role-based kind of approach to whatever you do, so the care team can access the same data with subset of things that they can be reading and using. Communication channels, like there are chatbots, there are voice, there are like phone calls and visits. So ideally, you don't want to tell people, okay, here's an app, you just use an app, or here's just a chatbot. In ideal way, I might be able to go to an app, enter medication, and then continue getting reminders, and you can check on me via chatbot. I'm not repeating anything, it's all integrated experience. Personalization, I talked about that. So everything from a content, to features, surveys have to be personalized. It was the first time you ask male patient, when was your last period? You lost that patient. He will never come back. I mean, yeah, but that's what happens, because we build like one size fits all app, and then we expect people to use it. But like if I don't see value for myself based on my cancer type, stage, my age, and everything else, I'm not using it. So this is very important. So my cardio coach. So the goal of this app that American Heart Association set up on our platform was to help people who have heart attack to prevent repeated heart attacks, because that number is very high, right? And again, it's available in App Store, it's free. You can download My Cardio Coach. You can play with it. Everything you see is configurable, customizable. So what you see is like a print screen that we did. That's how it will look. It's a dashboard where people can come in, and what I like in terms of the framing that American Heart Association decided to do with the app, that everything that people potentially want to deal with who have heart attack is within the one framework, from capturing the health data, and the health data can come from them entering data, from Apple Health, Google Health, any wearable devices, any integration to HR is available as well. So it could be integrated data dashboard. You have lessons and assessments. You have medication adherence. Is it my phone? Oh, sorry. Wow. Oh, it's my daughter, and I have her on exception list, meaning that she calls go through. It's in silent. Anyways, it has lifestyle, so people can set up their lifestyle goals and manage their lifestyle goals. It has capability to find closest cardiac rehabs and schedule appointments. It has all the reminders. It even has depression assessments, because there is a correlation between depression and heart attack. So basically, people can come to one place and do most of the things that they want to do. So here's more examples of health data tracking. Now, and again, all this, if you need to capture something else, you drag and drop field. We don't need to change single line of code. And if they consent, they can pull data from all the other data sources. Lessons assessments. On the back end, we can see the usage of every module, because it's important for us to understand what people like to use, why they use. They use a lot of this content, but it has assessments, and they can see how and you can assign like gamification points and carrots, so they do what they want. Medication tracking. So there is also a chatbot that basically can check on people. So did you take? You didn't take? Why you didn't take? We can capture, analyze. It's all AI supported on the front end and the back end. Goals and action plans. So we talked about lifestyle, and what American Heart Association did based on their research. They said you can tell people walk 10,000 steps a day, and people will not. But if you empower them to set up their own goals and manage them, the likelihood that they will start doing that increases. And we also built a different capability that's not deployed here yet, which is adaptive care plan, meaning that we can look at all the data points and adapt your care plan